So I'm going to talk to you about synthesising the evidence to support breastfeeding practice. And one of the great things about going when other people have already spoken is that they've already set the scene for me. So a lot of the themes that have already been alluded to will resonate with my own presentation, which is great because I can confirm what's gone on before. So first of all, I just want to ask, do we actually need any evidence related to breastfeeding? And I don't need to tell this audience of the benefits of breastfeeding. We know it's about warmth, we know it's about bonding, we know it's about security, and these things are all important. So if we have something like that, that's so great, why do we need the evidence? And throughout my career, I've heard lots of quotes like these, lots of people saying things like, it's something so natural, all women can do it, and it's like riding a bike. So let's look at this like riding a bike. Think about when you learnt to ride a bike, what it was like. Once you've got the bike, it's free. It doesn't cost you any fuel or anything. It's good for you. And once you get going, it's a real pleasure, isn't it? But then imagine that you hadn't seen anybody ride a bike before. Imagine somebody just turned up with a bike and said, off you go. How would you feel then? Would this make it more difficult? And then imagine you had a friend who had ridden a bike before, but she really struggled with it. She kept falling off. She didn't find it a pleasure. She was hurt and she showed you the scabs on her legs. How would you feel about it then? But being motivated, you persevered. You bought a bike, you read all the books, you knew the theory, you could do it. You were determined to be successful. But what's missing here? What would make you succeed? Anybody notice what's there in the picture? It's this person here, isn't it? The person who's offering support, who's going along that journey with you, the person that's offering encouragement and motivation. These are the things that are needed. So maybe we do need the evidence to find the best way to do this. And when we look at some of the global figures, you can see that breastfeeding rates vary across the globe, which does suggest that in some areas more support may be needed than others. You can see that the dark green colours are where breastfeeding at 12 months is prevalent, and then the lighter colours, for example the white of UK, is where very few people at 12 months are actually breastfeeding. So we have a bit of an issue. And if we continue to look at the global situation, we know that 78 million babies globally are not breastfed within the first hour of life. So that's 3 in 5 babies. That's huge. And this puts them at higher risk of death and disease and makes them less likely to continue to breastfeed. So if we look a bit closer to home, and you can see the rates in England, and you can see that these are pretty unacceptable. 74% of mothers start to breastfeed, 44% are breastfed at 6 weeks, 36% at 6 months, and only 1% of babies exclusively breastfeeding until they are 6 months old. So not a great picture. Now everybody reports their statistics differently, and I chose just 2 random ones related to Ireland. So this isn't Northern Ireland, this is Ireland, and 60% of babies are breastfeeding on discharge according to the Perinatal Statistic Report 2016, and 49.5% exclusively feeding. And then there's a paper in press at the moment that shows that 10.5% of mothers breastfeed exclusively for more than 6 months, 37.7% for less than 6 months, and 50.1% said they'd never done it. So again, not great. And this chart, I'll just give you a minute just to focus your eyes on it really. This was a surveillance study that was carried out by the World Health Organization, and it's currently in press at the moment. And what they did was they did a surveillance of 22 different European countries. UK isn't in this, but Ireland is, which you can see here. And the red bar shows never breastfed. So you can see across the 22 countries that Ireland was actually the worst. And then if you see these yellow bars here, this shows the exclusive breastfeeding at 6 months. And again, you can see that Ireland here is quite poor. But there are problems across the globe, and it's not unique to high-income settings. Last week I was here, stood outside Matundu Community Hospital, where we're doing a large study related to respectful maternal and newborn care. And you can see with their self-made board that they're really trying to promote breastfeeding. But even here in Malawi, breastfeeding rates are falling. So in 2011, 71% were exclusively breastfeeding, and this has dropped by 10% in 2016. So we need to do something in order to make sure that the low-income countries do not follow in our patterns. So why are rates so bad? If everyone that wanted to breastfeed succeeded, then perhaps we wouldn't need scientific evidence, but we know that they don't. So we do need to look to the evidence to see what is it that we can do about it. And I'm sure that you're all familiar with the Cochrane Library. The Cochrane Library, in case you don't know, is a repository of systematic reviews. And it collects trial data and synthesises that data in order to give more powerful results. And it looks at trials that have looked at specific interventions. So this is going into the Cochrane Library and looking at breastfeeding studies. And there's actually 113 Cochrane reviews. Okay, and within those reviews, there's over 4,600 trials. So there's been a huge investment into trials of interventions to try and improve breastfeeding. So that's taken an awful lot of time and an awful lot of money, yet still we don't improve our breastfeeding rates. In addition to the trials, there is lots of other types of data as well. We have the systematic reviews of RCTs, but we also have meta-synthesis of qualitative data. We have the primary research, and we have implementation research. But actually we have less implementation research than perhaps we should have, because often we find out that something may work and then we just expect it to happen. And in reality, that is not the case. We need to get much more savvy in midwifery about carrying out implementation research to find out what is the best way to make that change when we've identified that an intervention will work. But just looking at PubMed and looking outside of the Cochrane, you can see that there are 54,651 studies in that one database related to breastfeeding. huge. So how do we apply the evidence? And this is really important, and I was really pleased that previous speakers have talked about culture, so thank you very much for that. That was really helpful, because we know that breastfeeding doesn't happen in that vacuum. It's about culture, it's about environment, it's about peers, family support and body image. And I'm going to return a little bit to the body image shortly when I talk about a programme of work related to BMI and breastfeeding. Well, first of all, I just thought I'd share with you some interesting facts. So this is a few years ago now, but you can see that this chart looks at how acceptable people think it is for a woman to breastfeed in public. And this was a comparison between French women, American women and British women, and the same for the men. And you can see here that British women and men fare quite well on this. We could do better, but it's not too bad. But then the question was, where do you think it is generally acceptable for a woman to breastfeed? And I'll just give you a minute to look at this. And I'm not sure what you take from this chart, but the one thing that I take from this chart is that it seems to be that the closer to the public a woman is, the least acceptable it is for them to breastfeed. So it's more acceptable for them to breastfeed in a public toilet than it is in a restaurant, which is obviously totally unacceptable. And in a park or on the beach, where they could be miles away from anybody, it seems to be more acceptable than if they're in close proximity. So this is all really wrong. And I do like this quote here. If my breastfeeding offends you, feel free to put a blanket over your head. And somebody earlier was talking about putting a blanket over their head or a white tent. Well, maybe it should be the observers that put that over their own heads. That would be much more acceptable. But people are going to a lot of effort now to make changes, and that's really positive. And this was an article in The Guardian that was praising some of the latest stores that have got adverts showing women breastfeeding. So this is talking about the Aldi supermarket, Sainsbury's supermarket, and also Adidas, and saying that it's, you know, that they're embracing breastfeeding, which is a positive. I'm not going to show you the advert, but this was the Aldi advert, and what was so good about it was that the couple were chatting away about Aldi. It wasn't specifically about breastfeeding, but they were just incidentally breastfeeding, so normalising it. And there was lots of posts congratulating Aldi on the way that they did it, and I think the more we have of that, the better. So body image is really important, as I said previously. So what I'm going to do, I'm going to share with you some of the work that we've been doing recently related to BMI and breastfeeding. But I just want to first of all give credit to the team, and this is actually the work of one of my PhD students, Stephanie Lyons, and the other co-supervisors, Debbie Smith, Sinead Curry and Sarah Peters. So this is very much a psychology PhD with obviously midwifery expertise as well. And Steph has done her PhD by publication, so a lot of her work is already out there that you can follow up on if you want to. But I'm going to take you through the different stages of it to try and demonstrate to you that we can't just go in with an intervention and hope it works. There are lots of stages before you develop that intervention, and then you need to think carefully also about how you implement it. So just a little bit of background. Myself and Debbie Smith conducted a programme of work around obesity, pregnant women who had a body mass index of more than 30. And the breastfeeding work that we conducted has actually built on this work. And what we found, and others have found, was that women were less likely to initiate breastfeeding, they had a shorter duration of breastfeeding, and it did appear, although we weren't looking at statistical significance, that those groups that had social support were more likely to breastfeed. But importantly, it was also a period of change. So pregnancy was an opportunity where people would listen and would change their behaviours. So this was the premise of the work that we conducted. So we've conducted a programme of work. We had patient and public involvement and stakeholders right from the outset of the project, right from the design to the end, and they are still with us now. We conducted a systematic review. We did a meta-synthesis of qualitative research. We did secondary analysis of data that we'd previously collected. We did some qualitative inquiry and then developed an intervention. And in case you get disappointed at the end, I'll tell you now, the intervention is just being piloted, so we don't yet know whether it works. Okay, so just managing your expectations there. So in terms of our PPI and stakeholders, what we aim to do is to explore what research is needed to help women with a BMI over 30 breastfeed. So this was our very starting point. Got everybody together to find out, what does matter to women, what matters to the key stakeholders. And things arose, like BMI closely closes avenues in pregnancy, it shuts doors for women. So medicalised, and women really wanted to take control. And also they talked about the physical barriers like clothing, breast size and pregnancy complications that all hindered their breastfeeding. And it really gave us invaluable insight to enhance the research, to formulate our research questions, and also to design the optimum study. So then we went on to conduct a systematic review. And in all good systematic reviews, you need a focus question. And our question was, which psychological factors are associated with breastfeeding behaviours in women with a BMI of more than 30? We identified over 7,000 studies, and based on our criteria, we included 20. We identified 16 psychological factors, which related to 5 categories, which were intention to breastfeed, expectations and beliefs about breastfeeding, maternal confidence, mental health, and breastfeeding knowledge. And I think that all of these have been mentioned at some point this morning, which is great. I'm not going to go through the whole systematic review because time doesn't permit, and at some point you do want to go for lunch. But just to tell you the implications of the systematic review, we found that without a doubt psychological factors are associated with breastfeeding behaviours, and we came up with some recommendations about what health professionals can do in terms of encouraging women to plan to breastfeed, promoting women's ability to breastfeed, and signposting to breastfeeding support groups. However, we felt that our review was inconclusive in terms of developing an intervention. There wasn't enough there to say we could go from systematic review to intervention, so we needed to do more work. So then we decided we would conduct a meta-synthesis, because although the systematic review looks at interventions, it's also important to know what the experiences are as well. So we wanted both perspectives to be included in our intervention development. So our aim was to combine relevant qualitative findings to understand the perceptions and experiences of women with a BMI of more than 30 who breastfeed. And based on our criteria, we included 5 studies, and we had one overarching theme, which was that weight amplifies breastfeeding difficulties. So even though women have difficulties breastfeeding of a normal weight, it's amplified if women have more than 30 BMI. We also identified 3 sub-themes. And here on this chart you can see the sub-themes. And this paper is actually published in Maternal and Child Nutrition if anybody wants further details. First sub-theme was psychological reactions to medical intervention, perception of body's ability to breastfeed, and additional need for support. And I'll just give you some examples of some of these. So if we look at psychological reactions to medical intervention, women with a high BMI were labelled as high risk in pregnancy, and this meant that they often felt out of control. They were usually disappointed with the birth experience, and they felt that there was a lack of privacy, and all this led to them feeling unmotivated. So just a couple of quotes here to illustrate. Eve, these are pseudonyms by the way, said, "I was just shaking all over, like complete shaking, so I was like, I don't feel like I can hold him." So this was a woman due to her medical condition feeling that she was unable to hold the baby and didn't get any support to do so. And then Alison said, "And then I got really bummed because she was only able to stay on me for a couple of minutes. The nursery came and got her because her blood levels were low. So the baby was removed, and this really unmotivated her to carry on." So if we look at the next sub-theme, perceptions of body's ability to breastfeed, and this was about difficulty latching and positioning and difficulty finding clothing. And this created a lack of belief in the body's ability to breastfeed. They felt they were unable to plan, and they lost that belief in the breast milk quality. So all the time these things are making them feel unmotivated. And this was actually from a health professional. They said she's probably over 300 pounds and tried to breastfeed, but this poor little baby, you try and nurse a little tiny baby and their nose is right next to their mouth, like truly was smothered by this woman's breasts. And I think the effort that it would go into for her to breastfeed was just too much. So this lack of belief in the woman being able to do it. And there's clearly additional need for support. When we look at latching and positioning, there was actually very, very little support to do this, and lack of social support as well. And women reported that they felt a nuisance. They didn't want to ask, and they felt uncomfortable. And there was a misunderstanding about the purpose of the service. They didn't feel that they could ask or that service was available to them. And this was a lactation consultant who said larger women don't even want to expose any part of their body, let alone their breast. You can be as private or as discreet when you have larger breasts, larger body. So it seemed to reinforce what the women believed. A lot of the health professionals also didn't believe that the women were capable of breastfeeding because of their weight. So from this meta-synthesis, what we gathered was that women's weight amplified their breastfeeding difficulties. And similarly to the systematic review, we found that women needed to be empowered to breastfeed despite medical intervention, promote women's ability to breastfeed and produce good quality milk, and signpost to ensure understanding of the purpose of breastfeeding support. But again, we were still a little bit cautious about how do we build an intervention based on this. The pieces were starting to come together, but we weren't quite there. So we decided that we would actually look at the psychological factors in much more detail. And to do this, we did a secondary analysis of some previous data that we had. So the aim was to identify whether psychological factors associated with breastfeeding are reported by women with a BMI of more than 30 as part of their breastfeeding experience, and to examine how these factors influence breastfeeding behaviour. So this was data from 18 interviews with women with a BMI of more than 30 who'd breastfed. And we used deductive thematic analysis using framework of psychological factors identified in the systematic review. And all psychological factors reported, there was 1,048 quotes that were coded. So even though it was only 18 interviews, there was a huge amount of data. So I'll just take you through some of the themes that were identified. The first one being intention to breastfeed. All women intended to breastfeed, but different plans for duration. Intention motivated successful initiation. So if people really wanted to do it, they were more likely to initiate. If women were not unsure of whether they wanted to, then often what happens is then they don't. Planning short durations increase their confidence in their ability. So when women said that they wanted to breastfeed, and say for 12 months, they were less likely to do it than if they had short-term goals. Maternal confidence. Confidence in their ability was extremely important, and this grew once they received support and encouragement from other breastfeeding women. So peer support was really important. And they also needed confidence to breastfeed publicly. So this seems to be a recurrent theme that's been coming up all day. Expectations and beliefs about breastfeeding. Women believed in their breast milk's nutritional adequacy and sufficiency. So when women believed that, then it was helpful. Others' approval of breastfeeding was important, and women had positive beliefs about breastfeeding, expected breastfeeding to assist weight loss, because that was also a motivator. But these expectations really needed to be realistic to avoid negative impact. And breastfeeding knowledge. Factual knowledge promoted control and confidence in the person's ability to breastfeed, and social knowledge increased confidence and facilitated factual knowledge sharing. And psychological well-being was a final theme in the secondary analysis. And what we found here was that poor body image leads to low confidence in the body's ability to breastfeed and breastfeed in public. Women feeling down, anxious or stressed gain factual knowledge and social support to help them to continue breastfeeding. So even those that were feeling down, feeling anxious, if they got the right support at the right time, then they were more likely to succeed. This photograph is actually of one of the PPI women who helped with this study. So then if we look at the interview study and see what we learned from the experience of women. So the participants were women with a BMI of more than 30. They had breastfed or were breastfeeding, aged between 18 and 45. We did online recruitment by email and social media groups, conducted telephone interviews, which were semi-structured interviews, and these were PPI informed, audio recorded and transcribed. And we used inductive thematic analysis, and you can see that this paper is published. So what we found was personal control over breastfeeding behaviour was one of the themes, with 2 sub-themes: seeking support to overcome a medicalised experience and seeking information to overcome social and practical barriers. And as Freya said, I found it a lot harder because I had bigger breasts. And even just the fact that because I've got a little bit of weight around my middle means that being able to get him like closer into me when I'm breastfeeding has been harder. So the next theme was realistic expectations of the breastfeeding journey. And 2 sub-themes: being informed about weight, nutrition and breastfeeding, and normalising maintenance beyond 6 months. Because often women knew about the 6 months, but for those women who want to breastfeed beyond the 6 months, they felt that they often didn't get much support or information. And Bethany said, all the literature and everything was all geared up for like 6 months, isn't it? And then you kind of done your bit. Past 6 months, you kind of get in the, how long are you going to be feeding him for? After a year, they just realise you're slightly weird. And this probably resonates with people here as well, because, you know, you do hear that. You do hear people questioning, well, why are you still breastfeeding? It doesn't seem to be very well accepted. So what we gained from the qualitative work was that obviously it's important that we do encourage women with a BMI of more than 30 to breastfeed. And these studies explain why these women are breastfeeding less and perhaps what we can do to help. But I think the psychological factors really influence the breastfeeding behaviours, and I don't think we've paid enough attention to these. What health professionals can do is encourage women during pregnancy to plan to breastfeed for initially short durations, but to review and extend in line with WHO recommendations rather than always starting off at that target. Promote benefits of breastfeeding only when accompanied by realistic expectations. Inform and support women to lose weight safely whilst they're breastfeeding, and this is always a tricky one in terms of weight loss. It's always very sensitive, and often health professionals don't want to initiate that kind of discussion. But as I said previously, from our previous research, it is a really good time in pregnancy and the postnatal period when women are prepared to listen and are prepared to make behaviour changes. Discuss the benefits of attending breastfeeding support groups and help women regain control over their own decisions. So in terms of the interventions, clearly we need evidence-based interventions. Now the interventions that we looked at within our systematic review, 3/4 of the previous interventions that were trialled were unsuccessful. So it's what we call negative trials, so they made no difference. But a lot of the studies were really limited methodologically. They were not theoretically informed, and none of the interventions were psychological interventions. So this is clearly a gap in the evidence. So our intervention's been built on women feeling in control of their breastfeeding behaviours, particularly when high risk. And I know this fits with some of the work that Marlene and her team are doing. It's about increasing realistic expectations, aligning health professionals' training with women's needs, and raising awareness of the importance of confidence and body image. So what we wanted to do was design an intervention to support intention and maintenance, and I'll just tell you a little bit about that. I think I've got that. So within our intervention, it's about peer support, it's about self-reflection, it's about engagement in various activities, and one aspect of that is this workbook, Your Breastfeeding Journey. I don't expect you to read all the writing on here, by the way. And if people do want to know more, there is a Facebook page as well. But I'll tell you a little bit more about this. So this has been built on a theory. I'm not a psychologist, but the rest of the team are. But the workbook was based upon the integrated change model. And this model states that the primary determinant of a person's behaviour is their intention to perform that behaviour, but that this can be influenced by ability factors and barriers that get in the way of a person performing that behaviour. So that means if someone intends to perform a behaviour, i.e. breastfeed, if their ability factors are high, so if they have the ability to breastfeed, and the barriers are low, so there aren't any obstacles in their way, they're more likely to perform that behaviour. So it makes sense, doesn't it? So you're looking at ability versus barriers and trying to weigh that up. You want to increase the ability and reduce the barriers. That's what it's saying in a nutshell. So within the workbook, there are lots of different activities that women can do. They either do it on their own or with their peers, and like myth-busting breastfeeding quiz is one of the activities. Why is breastfeeding important to me is another one. And there's lots and lots of different activities that they can do. They have the option of attending peer support groups as well, and they have an active Facebook page as well if they don't want that face-to-face engagement. Now, this intervention is currently being piloted by Stephanie, and depending on the outcome, we would take it further. So that's where we're at this actual process in time. So I just want to end really by going back to my original question, do we need the evidence? And I would say yes and no. I think no, we do not need to prove that breastfeeding is better. You wouldn't believe that there are still papers that are trying to do that. I think we know that beyond shadow of a doubt, breastfeeding is better. But we do need to find the best way to support women to achieve their individual breastfeeding goals. I think that's really important. But these do have to be properly informed, and they do have to be rigorously designed. And I do fear that often breastfeeding is a subject that people will conduct research in, lots of small studies, but we perhaps need a concerted effort and some collaboration to tackle some of the real issues, to come together, to look at the various populations, to carry out some meaningful research, because when I showed you the Cochrane review and you saw how many trials have been carried out, and often these trials are in one centre, one site, one intervention. You know, breastfeeding is complex in terms of a research subject. And I think that we need some complex interventions to be properly piloted, properly researched on a large scale to see what can actually work for different groups of women. Thank you for listening.